Starting patients on BRAF and MEK inhibitors does take quite a bit of education to the patient, and I think from my perspective the most important approach is to really inform the patients of what to expect, and we spend some time with them kind of even going through the timing of different potential side effects. I highlight the fact that they need to try to hydrate themselves very well, for instance. When they start experiencing any sort of fevers, it starts usually with chills that, then go to low-grade fever, then go to high-grade fever. So I make a really significant point for patients to really, and harp on that several times, that if you start experiencing that sequence from chills to low-grade fevers, that would be a really good time to actually stop your medications. It's interesting because most patients are really concerned about stopping early a medication that they know is designed to help their tumor, but we really educate them that those dose interruptions are not necessarily going to impact the efficacy part, right? So that's kind of one big aspect of really focusing on the fever and educating them of how to manage it and how to hydrate themselves to prevent worsening of the fevers or kind of resulting in hypotension or renal failure or anything like that. The other piece is we educate them about sun safety, which is part of our education for any melanoma patient, but we also kind of highlight the fact that they may be a bit more sensitive to the sun depending on which combination we use, obviously. So if we're doing vemurafenib, cobimetinib, that's a significant discussion because patients can really have a lot of issues with photosensitivity. And at the end, we do highlight the fact that, if those side effects do happen with you, reach out to our team. We really highlight and stress the communication piece, and for those patients to really reach out to us and ask us questions. And our team is really, then handles those things, basically assesses how severe the patient's condition is, and then kind of really gives them the best ways of how to handle that toxicity. But again, to summarize all of that, I would say a lot of patients' educations up front, and once they're past the first 2 to 3 months, then they've learned exactly how to deal with this. You've learned how they handle the medications, and they do get, kind of a bit more on autopilot after that.
We don't know whether dose reductions or scheduling shifts in dosing have an impact on outcomes. Logically speaking, if we're giving less drug, we have a lower exposure, not just in the blood, but in the tumor, and that the melanoma may be able to develop resistance more readily. We know that's true in test tubes. You can give low doses of BRAF and or MEK inhibitors and generate resistance. But we don't know whether that's true in people, but logically speaking, it may be true. The other thing is we don't know what the individual dosing level is in a patient. We don't have real-time pharmacokinetics on every patient, so there may be some patients that take 450 and 45 BID of oncorafenib and binimetinib respectively and have very low relative dose exposures, and other patients who have relatively high. And so dose reduction may actually be the only way to get to the optimal dosing levels in the blood. We never know that for sure. It's whether side effects are driven by more, sort of higher PK in individual patients, or whether it's driven just by some patients are going to develop that and some patients aren't going to develop that. So it's hard to know for sure whether dose reduction is going to impact outcome. If it's the scenario where a dose reduction just leads to a more normal dosing level in your blood, it shouldn't impact outcome. Whereas if the dosing level reduction leads to lower doses of the drugs in your blood system, it probably will impact outcomes. And so what we often try and do is maximize the amount of drug we give. Sometimes we do that by embarking on strategies to mitigate side effects symptomatically and continue to dose at high doses. And sometimes what we'll do is we'll think about dose hesitations where we'll treat for a period of time, then give a break, then treat for a period of time, then give a break, treat, and give a break. There's actually data to support that that is not detrimental. Of course, that data is in mice, not humans. But there was a really interesting study in mice that showed that if you treated In this case, I believe it was vemurafenib. So you treated melanoma in mice with vemurafenib. The tumor would shrink, you'd stop the drug, the tumor would grow. Once it got to a certain size, you start it again. And if you did that strategy of dosing and holding based on what was happening to the tumor, those mice lived longer without ultimate progression than did mice where you were just treating with the same dose all the time, every day. So that's led to some clinical trials that are ongoing to see whether this abbreviated on-off or intermittent dosing would lead to better outcomes. We don't know the answer. But in somebody who's having trouble with toxicity, I feel more comfortable giving intermittent dosing of the real dose as opposed to making up some dose and giving continuous dosing with that. Now, have I done lower doses? Of course I have. And oftentimes it includes those patients who've had trouble previously with other BRAF MEK inhibitor combinations, and so I'm modifying the dose on the run. It's actually quite easy to modify the dose with oncorafenib and binimetinib because you're taking 6 pills of oncorafenib a day and 6 pills of binimetinib a day. Binimetinib's 3 pills twice a day, but still, it's, again, easy to take away 1 or 2 of those pills and modify the dose to something that you can really titrate tolerability based on the toxicity that patients are having.